Okay, can everyone hear me?
Yes, madam. We can.
So I guess you all are tired but can't help. We'll continue, right? Okay, so I think you all have enough stamina to continue. So I'm Dr. Sinani. So we'll discuss about uh, respiratory support and mechanical ventilation. All right. Okay. So right. So it will be a sort of an interactive session. Usually, I don't let you all sleep or doze off or be quiet on the other end. And I'm just checking whether you all are really online. Okay. All right. Okay. So let's discuss about respiratory support, including mechanical ventilation. All right. Okay. So let's start off with. Uh, So I have a couple of aims of this lecture for you all to gain knowledge actually. So you all already know about ventilation, but I am just going to emphasize this basic principle of ventilation and what are the types of different respiratory support that is available for us. Okay. And what are the indications for mechanical ventilation? There are very simple indications, okay, which is very easy to remember. Okay, and common modes of ventilation which are very commonly used as y'all, once you become house officers, registrars, senior registrars and consultants one day, y'all all will be using these same modes of ventilation, and also the complications of ventilation and how to set up a ventilator for mechanical ventilation. Okay, so at the end of this lecture I expect you all to understand the basic principle of ventilation and application of different types of respiratory supports for different patients, and application of different non-invasive ventilatory modes to patients, and as well as to identify application of invasive ventilatory supports to patients. Okay, so let's go through the lecture. And so what is ventilation? So ventilation is, so somebody might say it is breathing, isn't it? So we are, if anybody is alive, they are breathing in and out, isn't it? They are trying to get oxygen in and they're going to wash out carbon dioxide, isn't it? So that is what is happening during ventilation. Okay, so and that is a process of getting oxygen from the atmosphere to our blood. So it has to cross the blood gas barrier. Um, and the lungs should give out the carbon dioxide out to the environment. Okay, so Hasinta, can you tell me what is the blood gas barrier? Where does it located? Hasinta or Hasinta Samarakon. Uh, can you please tell me where is the blood gas barrier?
Madam, respiratory alveoli.
Yeah, that is the respiratory level. So, what is the importance about it? What is so specific about it? What do you know about it? Actually, basically, what sort of a layer is that?
It is the simple squamous epithelium.
Yeah, and
Uh, Blood gas is diffusion to the blood in from air, madam. From alveolar gas diffuse to the blood.
yeah, very good. So it is a very thin membrane, isn't it? So next to that thin membrane, what is there is the blood vessels, isn't it? So what sort of blood vessels have you got there? Are there like very muscular, large blood vessels?
Cap-
So
no, madam, capillaries.
those are also,
Capillaries.
yeah, so that is right. So those are also capillaries, isn't it? So they have a very thin endothelium, and it is a single layered surface, isn't it? And how about the surface area? How much is the surface area like? How much do you think is the surface area of the whole, or if you take the whole two lungs and the alveoli, how much do they say normally? I mean, as a rough idea, how much have we got the surface area with regard to the diffusion surface area?
About tennis court.
Yeah, they say, isn't it? I think it's a rugger court, isn't it? Not a tennis court. I think tennis court is too small, I guess. Okay, so you're right. So something to do is that much of a bigger in surface area, isn't it? So that idea you all should have. Okay, so So it is being made in such a way to facilitate the gas diffusion. So which is the gas which is more soluble in fluid? Is it oxygen or carbon dioxide? Uh,
Carbon dioxide, madam.
Yeah, carbon dioxide. Yes, good. And right. So let's move on. So with that basic knowledge, so you all know that the oxygen needs to push in and carbon dioxide needs to come out. So the ventilation, the main aim of ventilation, like the aim and the objectives of your lecture. So the aim of ventilation is to maintain oxygenation and also to remove the carbon dioxide. Okay. So let's see how it is happening. So
Excuse me, madam.
yeah.
Madam, the lecture is not being recorded. Is it possible to record, madam?
No, it is not being recorded. You all want it to be recorded? You all can have the lecture note later. Do you all want to
Uh,
record it?
yes, madam. We think it's better if we can record.
Why are there a lot of absentees? Okay.
Yes, madam.
Uh-huh. All right, I'll start recording, but I think it's good for you all to, well, you know what happens when you record? It is a sort of a negative feedback onto your head telling that, okay, I don't have to listen now, I can sleep now, and I can get another time to listen to this separately. Okay, so you're going to spend double time to concentrate on one lecture, isn't it? So I think that is not really good. So better to concentrate now.
Recording
Okay?
in progress.
All right. So anyway, I'll start recording. So right. So we are just going to discuss how does breathing happen. So during inspiration. So or else I'll ask Janani. Janani, can you tell me by looking at my picture? Can you describe how does inspiration happens? How does inspiration take place? What happens during inspiration?
Due to the negative pressure,
How do you create a negative pressure?
air has to come into the lungs. With expansion of six and diaphragm,
Mhm. So what happens to the diaphragm?
diaphragm
I can't
moves
hear you
down.
clearly. Yes, the diaphragm moves down and the intercostal muscles contract and it has this bucket handle movement and they all congregate together and the chest wall AP and AP diameter increases. Okay. So when the intrathoracic volume increases, there is a negative pressure that is created within the chest cavity. Okay, so with that there will be a negative pressure that is being built up on this graph. You can see this is the zero level and with inspiration you all can see the alveolar pressure drops to -1. Okay, -1 centimeters of water. So because of this negative pressure, there's air that is being inhaled will be dragged into the lungs. Okay, so look at this mechanism carefully. That is what is exactly happening afterwards. So then it reaches again once it comes to a equilibrium. So the air comes in and starts moving in, and at some point it stops. uh, the inward flow will stop because of the equilibration of the pressures. Okay, and then it is a passive expiration. So during passive expiration, what are the changes that are happening in the lungs? Can K, I can see only a K on the as a guest. Can you please tell me how does exhalation happens? I can only see a letter K. I'll ask you to unmute. Who is K? Could you please put down your M number, M/15, your batch number, please, so that it's easy to ask questions. Otherwise, others will have to wait. And there are two M15s. Could you please put your numbers, please? Who is K? Can you all please put your first name, please? Damsara, Damsara, can you please explain how the exhalation happens? How does exhalation happens? Quickly. We don't have much time. If you all take lot of time, you all will have to stay on the lecture for a long time. Okay?
Madam,
Yeah. How does
madam,
exhalation happens? Now I have shown you all pictures.
then
Describe.
the diaphragm relaxes and it comes up,
Yeah.
and then the thoracic cage, the intercostal muscles also relaxes,
Mm-hmm.
and the thoracic interthoracic
I can't hear you all. Can you all hear me?
Yes, madam.
Okay. So what happened to Damsara?
Madam,
I couldn't hear you actually. I could hear about the diaphragm. I didn't hear the rest.
madam,
Yeah, I couldn't hear the rest. I heard about only about the diaphragm.
madam, diaphragm relaxes and it comes up,
Yeah.
and the thoracic, the intercostal muscles also relaxes.
Mm-hmm.
So the thoracic, so the interthoracic pressure, interthoracic volume reduces, and the interthoracic pressure increases.
Mm-hmm.
Then the atmospheric pressure, so the exhalation happens.
Okay. All right. So that's how it is. So it is a passive process, isn't it? So there's lung recoil and chest wall also recoils. So with that, you will see the pressures go up. You can see the alveolar pressures going up to +1, and then it settles back to 0 because it equilibrates with the atmospheric pressure. Okay. So that's how the inhalation and exhalation happens. So inhalation is active and exhalation is passive. Okay. So this is the normal inspiration and expiration curve. All right, everyone understood?
Yes, madam.
Okay, so now let's see how to achieve this airflow. So, by creating a negative pressure within the lungs, as occurring in spontaneously breathing humans, you create a negative pressure so that the air goes into the lungs. But uh, during mechanical ventilation, what we do is we create a positive pressure, little different to what really happening in by nature. So we create a positive pressure and we push air into the lungs through a patent airway or an open airway. Okay, so that is what we do during mechanical ventilation. Okay, right. So you all would have seen already. You all would have seen different types of ventilators in our ICU, in the theater setups, in Candy, everywhere, right? So onto your left hand side is a conventional ventilator. So you have a little a screen, or you have this interface, okay, where we feed our numbers, and then you have the tubing system which is delivering the gases to the patient, and at the end you can see a yellowish circle which is the filter, and then here the test lung is hanging so that it is being tested on the test lung before it goes on to the patient, and you have the humidifier and the air warmer. Okay, so that is being incorporated because this is an artificial system. So whatever that is being done by the nose and the upper airway, such as humidifying and warming of inspired air, is being done by these instruments, which is in a sort of an artificial way. Okay, so this is used for mechanical ventilation. This is for for positive pressure ventilation, where we produce a positive pressure through a patent airway, and the machine is delivering a flow and it will reach the lungs. Okay, whereas you have the negative pressure ventilators, which was used long time ago. Initially it was started during the polio pandemic, and where this is a big chamber in which the patient is supposed to lie. Okay, so it creates a massive negative pressure around the thorax. Okay, so when the negative pressure is created around the thorax, it tries to expand the lungs, so it creates a negativity within the lungs, so that the air will be air will be just flown into the patient's lungs through the patent airway. Okay, but you all can see this patient is not intubated. All right, so this one is not intubated, and the patient is having with his or her natural airway. Okay, so that is called an iron lung. Okay, but you can also see the size of this. It looks like a rocket, isn't it? It's so huge when you compare with our modern conventional ventilators, which are very small, and it's very nicely, it could accommodate a little space at in our bed spaces in our ICUs. Okay, imagine if we had iron lungs, how big our ICU should be. So it should be like half of the hospital. Okay, because it's so big, right? So before sending this air or oxygen mixture to the patient, so it is being warmed and moistened, and it as it goes to the humidifier. Okay, and the expirated air also, which has carbon dioxide, flows from the patient back to the ventilator, and the waste is being expelled out from the ventilator. Okay, and even with this mechanical ventilation, the expiration is passive. We don't force the patient to expirate. We can't. Instead, we let the natural recoiling of the lungs to happen, so that the volume will get exhaled from the lungs. Okay, so let's discuss about positive pressure ventilation. Okay, so this ventilator creates a positive pressure inside the machine circuit, and which is being delivered to the alveoli, resulting in an inspirated gas flow into the alveoli. Okay, so there will be a forward flow towards the alveoli. Okay, so to achieve this, you need a patent airway. So how do you get a patent airway? You have to have either a endotracheal tube. Okay, if somebody is having an endotracheal tube, and if he is on a positive pressure ventilation, that is called as invasive ventilation. Okay, or in other ways, the patient may be um, maintaining his or her own airway, and they are conscious and rational. So in that case, we need a tight fitting face mask. All right, we need a tight fitting face mask, and a non-invasive ventilation strategy can be done with that. Okay, so that is how it is. All right, so so if you use a tight fitting mask, that is known as a non-invasive ventilation strategy. Okay, now could you all please put your first name, please? There's another one looking very anonymous. M15. I'll just send your request also to unmute, and please put your number or the first name, please. Right. So and M15 022. Can you please tell me, have you seen any non-invasive ventilation methods? What are the non-invasive ventilation methods that you all have seen? Have you seen any? M15 022, is he or she in the lecture or not? There are a lot of M15s without the last number. Why is that? You don't have to hide. Actually, you can just reveal yourself, right? M15 022. Please answer, right? Otherwise, I mean, it won't be effective. So I'll wait until you all answer. Can you tell me a couple of non-invasive strategies that you all have seen. I saw M15022, but now he's missing from the participants list.
Nasal cannula, madam.
Yeah, nasal cannula is not a ventilatory strategy. Okay, that is a way of giving supplementary oxygen. Okay.
CPAP, madam.
Yeah, CPAP is another mode of non-invasive ventilation. Okay, and so you need a tight-fitting mask. Have you all seen during this COVID pandemic? We have been using a lot of CPAP masks, so you all are quite familiar with all that. Okay, right. Okay, so I'll be asking questions from all 64. So, and since this is being recorded, if somebody's absent, that also can be recorded, I think. So please answer, right? Okay. Okay, so this is a kind of a setup of the right. So give me 1 second. So what are the components that you can see on this ventilator? What are the components that you all can see? Can you all briefly tell me based on what I described already? So if you can start from the patient end, M15094 Sumudu, can you tell me starting from the patient end? Can you please describe what equipment you can see to the patient? So starting from the patient end, what are the equipment you can see up to the monitor, up to the ventilator?
Nasal tube. ET tube.
Yeah, there is an ET tube. Yes, very good. And it is being taped, isn't it? So it is being taped, Sumudu. You can see the straps going right around patient's face, isn't it? And it is being connected to two tubings by a Y connector. Can you see this blue color bit? That is a Y connector. Okay. And then you have the inspiratory limb, which gives the red arrow towards the patient. And then you have the expiratory limb, which goes out from the patient to the ventilator. Okay, so this is the exhaust port or the filter where they filter all the sort of bacterial components, particles, and then they release filtered air out from the ventilator. And then you have the inspiratory limb, which comes through the humidifier and which warms and moistens the air that is being inhaled. Okay, and then that is the inhaled air that is reaching the patient ultimately. Okay, and also you can see uh, this is the here we have the compressors. So in the compressors we get a blend of medical air, which is actually the atmospheric air, but it is being filtered, which is known as medical air, and then it is being blended with oxygen. So depending on the percentage of oxygen we fix here, the patient get the set FiO2 through these tubings. Okay, so this is the interface of the ventilator, and there are a lot of buttons underneath, and with that we can set up our numbers parameters here, and we can see how much patient gets on the top horizontal bar. Okay, so whatever we set up will be appearing on this screen, and whatever patient is getting will be seen on the top screen. That's why you have lot of numbers on the ventilator, which that is not to confuse you all, but to show how much is being set up and how much is being delivered. Okay, however much we set up things, it doesn't matter unless the patient gets it. Okay, so the thing is, although we set up lot of numbers, depending on the patient's lung compliance, depending on the patient's airway resistance, the pathology behind the lungs, based on all that, the delivery will be impaired. Okay, so the volume delivery and the gas exchange will be affected based on the patient's lung condition. Okay, so because of that, you have to see what really patient gets onto this screen. Okay, right. So just to have a little sort of an interest on this, so this is the iron lung. You can see how crude it looks like, and this is the chamber where they creates the negative pressure. You can see the pressure regulators where they will set up. And this is the kind of, it is actually now belongs to history, and it only has a historical value. Okay. And then, so negative pressure ventilation, so there are a couple of advantages as well. In a way, it does not require intubation. So ET tube and the intubation related complications are less than, and then cannot overcome substantial increase in airway resistance or decrease in pulmonary compliance, because we don't have any control over the airway resistance, because it is being controlled by the patient and we cannot control it from outside. Okay. And the other problem is the patient is completely kind of encased within the artificial lung, so you don't have access to the patient, not even an IV access. Okay. So, and then the other problem is, if this patient is at a risk of aspiration, they can easily aspirate because the airway is not secure. Okay. And so we have two types of ventilator support. Basically, we have non-invasive and invasive. Okay. So let's discuss each. So these are the sort of non-invasive ventilator supports. So right. So have you all seen this sort of non-invasive ventilator supports during your hospital visits, ward rounds? So this is a high flow nasal oxygen therapy system, where you have, this is driven by the oxygen flow. Okay, so this is a special flow meter which can go up to higher oxygen uh, flow rates like 60 liters per minute, so on. So based on this flow rate, this is able to create a fraction of inspired oxygen concentration to the patient, which is very effective. Okay. So we just have to adjust the flow rate, but then ultimately it will adjust the fraction of inspired oxygen that is being delivered to the patient. So this is the nasal interface, where it looks like a little nasal cannula. Actually, you could say it's sort of a bigger nasal cannula, and but it is very well cushioned. So we call it as a nasal interface, and the patient gets the certain amount of oxygen flow rate through the tubings, and so there is a filter usually here, and then it has one link, because it's a one way oxygen delivery system. But because of the high flow rates, it is very handy in especially in weaning patients, or when we are like stepping up our respiratory support. So it is a good adjunct to um, from non-invasive to invasive ventilation. Okay. And you can see the inspirated tubings, and this is the humidifier. Okay. And this is the stand where it is being fixed into. Okay. Right. So by looking at this picture, M15096, um, could you please tell me, uh, by looking at this patient, what do you think? Okay, this is a non-invasive ventilator support, but what are the risks, in your opinion, what are the risks associated with this mode of ventilation?
Madam, we cannot supply adequate amount of oxygen through the non-invasive methods.
Here in this one, we can supply fraction of inspired oxygen, but apart from that, what are the other problems that you will see in this setup?
Exhaled carbon dioxide is collected.
Well, it can freely go out from the nostril. So if the patient, I mean, he can exhale nicely from the nostrils. How about if, just imagine if the patient keeps his mouth open, or if he's a mouth breather, what will happen?
The effectivity of the ventilator is
Yeah, of course. So
reduced.
yeah, exactly. So when the nasal cannulas are there, and if the high flow is going up, of course the patient should be able to keep his mouth closed. Otherwise, the effect is lost. Okay. So the air can leak through the mouth, and then the expected effect, or the expected fraction of inspired oxygen will not reach the lungs. Okay. So this is not a good one if the patient is a mouth breather. If the patient is more predominantly a mouth breather, this is not an effective method of in ventilatory supports, right? So in that case, we have to think of other modalities like a face mask, where it covers both the nose and the mouth. Okay, ideally he has to go for a CPAP. So what are the other problems that you can see on this patient? So he looks very comfortable though, but what are the problems that can happen?
uh, with movement, madam, this can device can mis- uh, detach. Uh,
Yeah, the device can get detached actually, because I mean it can fall off anytime, because I mean it is just fixed around the ear, isn't it? And the other issue is now his airway is not secured, isn't it? So I mean, as long as he being conscious, of course he can be on high flow. But at the moment when he becomes unconscious, or at the moment he becomes unable to maintain his patency of his airway, that's a risk of aspiration, isn't it? We are not protecting the airway here. Okay, right? So as long as the patient is conscious and rational, you can keep a high flow nasal oxygen. But if the patient is unconscious, or if the GCS is dropping, you have to think of a definitive airway. All right. Okay. So and the
yes, madam.
humidifier. So humidifying, you have to always check if the humidifying is going on. If it is not there, there's a risk of drying the nasal passage, because it's a very high flow rate and it can dry out the nasal passage. If that happens, they are in susceptible patients, they can even bleed from the nasal mucosa because it is very fragile. Okay, right. So those are the problems associated with the high flow nasal oxygen, right? So the indications for high flow is actually with during respiratory distress or with hypoxemia, where a patient, if he only needs a higher percentage of oxygen, then at that situation we can use like for pneumonia, bronchiolitis, bronchiectasis, sort of. And also during post extubation, sometimes there are patients who need bit of oxygen support and ventilator support, but they do not necessarily need to be intubated for that. So in that sort of situations, just to bridge the therapy until they recover into a Venturi face mask or a conventional oxygen face mask, we can use the high flow nasal oxygen. And then to facilitate weaning from CPAP. So imagine if somebody is on a CPAP and they are going to step down their respiratory support, so they can come back to a high flow. Okay, and then from high flow we can nicely wean onto a Venturi mask, and then to a simple pain mask, and then to a nasal cannula, and then they'll be off oxygen very soon. Okay, and then of course also post-operative respiratory failures, like sometimes there are patients who tend to, like, again we can extubate them, but still they are running on a high oxygen requirement. So in that situation also we can use the high flow. Okay, so the advantage is you don't need to intubate them. Instead you can give a high flow of oxygen, provided they keep their mouth closed. Okay, so those are the advantages. So it can deliver up to 100% oxygen more accurately as opposed to nasal cannulas. So in nasal cannulas, you can't go up on your floors, isn't it? So what is the maximum amount of oxygen flow rate that you can go in the nasal cannulas? Can Malisha, can you answer me, please?
4 liters.
Yeah, maximum is 4 liters. Okay, what happens if you go above 4 liters?
Can damage the nasal mucosa.
Exactly, yes, good. So, and what happens with nasal cannulas? What is the problem with them? So it dries off the nasal mucosa, and what else? So because of a lot of drying, again it can cause bleeding. Okay. Does nasal cannula work, by the way? Sahani, how does it work? What is the sort of kind of mechanism? How does it give us oxygen?
Mm.
So inside the nostril, you have a dead space, isn't it? There's a little dead space in the nostril. If you imagine the concha and the sinuses openings, so that area is a little dead space, isn't it? So what we are doing is, so imagine if somebody is breathing in, so the first bit of air that is coming from the atmosphere is, from the environment, is the bit of air that is at the nostril or at the nasal cavity. So what the nasal cannula does is, it keeps this nasal cavity enriched in oxygen. Okay, because it cannot reach the lungs, obviously, isn't it? Can the nasal cannula, these 4 liters of oxygen, can it reach the lungs? That flow is not enough. Okay, so what it only does is, it just enriches the nasal cavity, the air that is within the nasal cavity. So each time when a patient takes a breath, that enriched oxygen enriched air goes into the lungs. Okay, so imagine how little amount of oxygen it delivers to the lungs then. So that means the patient will be, very soon he should be comfortable on room air. Okay, right. So then the other advantage is, it also flushes the anatomical dead space. Can you remember the anatomical dead space? How far does it extend? So from starting from the nostrils up to the bronchioles, so you have the dead space. So this dead space is being flushed by this high flow, because it has a higher flow rate. It has the power to flush it. Okay, and it provides warmed and humidified gases and reduces the metabolic work. So how does it reduce the metabolic work? Let's ask M15094. M15094. So, I think Sumudhu, you answered. Sorry, Sumudhu, I'll ask someone else. Sorry, I'll give the uh, chance to someone else. There's one called Huawei. I don't know his name though. Uh, Huawei, who is that? I think his phone name only appears. I just ask you to unmute. Could you please put down your name or the this your registration number, please? So it is nice, so that we can quickly run through the lecture, because everybody needs to answer. Nobody will be spared. Who is Mr. or Miss Huawei?
Madam,
Yes, yeah. Hi, what's your name?
I'm Roshan, madam. I
I
disconnected and reconnected
okay.
there.
Okay.
Then it's happy as well, madam.
Okay, all right. So can you tell me uh, how does this high flow oxygen reduces the metabolic work? Any guesses?
Madam, as inhaled air has more oxygen, patient doesn't have to grasp for air when he has difficulty in breathing, madam.
Mhm. So, like when we inhale from the atmosphere, we are inhaling dry air. Okay. So, imagine these days, anyway, the environment is very dry, isn't it? So, whenever we inhale dry air, we need to humidify it. We need to warm it. So, the air that we are inhaling naturally is not warmed or humidified. So, we are supposed to humidify it and warm it to 37 degrees of Celsius in order to reach it into the lungs. If it doesn't get warmed and humidified by the time it goes to the lungs can get damaged. Okay, because the alveolar membranes are very fragile. Okay, so for you to warm and humidify, you can't do it without having any kind of cost. So you have to sacrifice some of your calories to warm and humidify these gases. Okay. So for an average adult has to have about roughly around 150 calories of energy needs to be used to warm and humidify these gases. Okay, Roshan, understand?
Yes,
So
madam.
so that is why I am telling you all, it reduces the metabolic work, because the high flow will already humidify and warm these gases, so that by the time it reaches the lungs, it is warm. So the patient no need to use any of his calories to do this job. All right. So that is how you can save some energy to critically ill patients. So ill patients, because their calorie amount in their body is very important. Okay, even 150 calorie will be very beneficial for them to reserve. Right. So because because they are spontaneously breathing, they have to use energy for breathing as well. So at least we can save some energy. and at the same time the positive airway pressure throughout the respiratory cycle is being maintained. So it's little similar to a CPAP, continuous positive airway pressure. Okay, during inspiration as well as during expiration, this high flow oxygen is being kept. It's like as if you will feel the experience of you sticking out your head in a moving vehicle. Imagine a gush of wind coming in and rushing into your face. So that sort of feeling will be there onto the patient when they are on high flow nasal oxygen. And also it potentially aids the mucociliary clearance, so which is a good thing, as there'll be a lot of the mucociliary escalation should happen to clear the germs and the bacteria, isn't it? So there are a few kind of so from the high flow we'll move on to another mode of non-invasive ventilation, which is known as CPAP or BiPAP. Okay, so CPAP is continuous positive airway pressure, and BiPAP is bilevel positive airway pressure. Okay, so which we are going to discuss in detail. So you can see onto your left hand side, this person is wearing a face mask which covers the nose and the mouth, and onto the other side is a person who wears even a bigger mask which covers the whole face, isn't it? So this is a full face mask. This is a half face mask, and there are another teeny tiny mask which cover only the nose. Okay, so any of these masks should be tight fitting. It should be according to the patient's shape, and it should be nicely sealed around, and there should be no air leaks. Okay, and then a patient should be advised on the feeling that they are going to have. Again, it's sort of a gush of wind coming onto your face, and it is little difficult because they have to breathe while that this amount of air is coming into their airway passage. So so in CPAP, let's see in each separately, right? So in CPAP, what happens is there is a continuous positive airway pressure right throughout the respiratory cycle. So now think back about that little graph I showed you all initially, inspiration and expiration. So in both parts of the respiratory cycle, in CPAP, they gives a positive airway pressure, whereas in BiPAP, they provide two levels of pressure, one during inspiration and another smaller pressure during expiration. Right? So let's see. Okay, so these are two types of ventilatory support. So in CPAP, it is the continuous positive airway pressure, and so there is a high pressure driven by air oxygen mixture with a tight fitting mask, and the positive pressure all the time to help keep the airways open. So there is a P, or a positive end expiratory pressure, all the time is being set to keep the airways open. Okay, so what are the airways that will get collapsed during expiration if we don't have a PEEP? How about M1500? M1500, can you tell me what are the parts of the respiratory tract that can get collapsed during expiration?
Alveoli.
Excellent. Yes, alveoli. What else?
Bronchioles also.
Yeah, what sort of bronchioles? So those are the small respiratory bronchioles, isn't it? Which doesn't have a good smooth muscle thickness. So they can quickly collapse during expiration. Okay. So in susceptible patients who are very weak and who cannot cope up this stress, so they are more prone to get have collapsed alveoli and respiratory bronchioles during expiration. So because of that, we need to maintain a positive end expiratory pressure to maintain the alveoli open. So then also you can use this in acute pulmonary edema. Okay, so in acute pulmonary edema, that is again very useful because during pulmonary edema, there's a lot of fluid accumulated within the alveoli. Okay, so if you apply a positive pressure, that fluid can be pushed away from the alveoli back to the vasculature. Okay, and also during sleep apnea, again the patients have obstructed airway and they are unable to maintain the patency of the airway. So where we can use the CPAP machines. So there are things called home CPAP machines for patients who have obstructive sleep apnea. And then BiPAP machine, so bilevel positive airway pressure, again quite similar to CPAP. The only difference is it has two pressure limits. So we have a high positive pressure limit and a low positive pressure limit. So the high positive pressure limit will support inspiration and low positive pressure will support expiration. Okay, so during expiration it will prevent the airway collapse, and this can be used in COPD exacerbations and ARDS. If you happen to come to the ICU these days, there was one patient in the this isolation rooms who was on a CPAP, and then he was a COPD exacerbation patient on which we use BiPAP mode. Okay, if your colleagues or your group coming to the ICU these days, you all would have seen. All right. So whenever if you get a chance to see, just look for those and see whether you all can gather at least a little bit of practical things that you have already learned. All right. So let's discuss further about non-invasive ventilation, and there are a lot of advantages. Okay, so in non-invasive ventilation, in the CPAP and BiPAP modes, you can deliver specific fraction of inspired oxygen and a PEEP and a pressure support, so that it will augment the respiratory efforts. So you can reduce the work of breathing of the patient. So you can let him rest a little bit. You are also supporting him. Okay, and do not need invasive airway adjuncts like endotracheal tubes. So a lot of hassle and bustle related to ET tubes are being taken off by these non-invasive ventilator methods. And the disadvantage is patient will be little discomfort because they have this feeling of massive gush of air coming and hitting on their face, and it's very difficult to talk, eat with, and also they can't drink and they can't clear secretions, and cannot be used in unconscious patients or who has very poor respiratory efforts. If they can't breathe, if their muscle power is actually very low, like in type 2 respiratory failures, it is not very effective. Okay, so the patient should be able to breathe on his own, and the gases are also not humidified. That is also a problem. Okay, right. So let's see on to invasive ventilation now. So for invasive ventilation, you need to intubate. Obviously, you have to intubate a patient and cuff the ET tube and maintain a patent airway. Okay. So it is being secured. So it should be nicely secured at the lip level. And you can see in this picture, it is being fixed onto the connectors and then to the ventilator. And what is this bit? What is this green color thing? Let's ask. M1547. Can you all hear me? Because there was a little power failure. You all can hear me, right? Okay, that's fine. So M15, what was the number I asked? 147. Yes. Can you tell me what is this green color thingy here? Can you see this green color thingy? What is it?
Yes, madam.
What do you think? What can that be? Hmm? What do you think that? There's a pink color bottle also hanging on the side. A plastic bottle. So this is a closed suctioning system, right? So this is a suction tube that is being connected to the suction catheter on the either side onto the wall sucker system. And this is a closed suctioning system that can go into the ET tube like that. And whenever there are secretions, it can suck them out and clear it. And then the tube again comes and lives inside this plastic or the polythene sheet. Can you see that? So it won't get contaminated by touching anywhere else. It only goes, seeps into the ET tube and comes back. Okay, you can just glide it in. All right. So, and this is a saline bottle that is hanging on the side, or sterile water where you use it for ET tube irrigation, and you can just suck the secretions out. Okay. So this is a closed suctioning system, which is very important to see even in our ICUs. You all can see these, right? All right. Okay, so what are the indications for mechanical ventilation? So it is very simple. There's only three indications. Okay, so first one is to improve mechanics of ventilation during ventilation failures. Imagine if the respiratory rate is less than 6, or if the respiratory rate is more than 35, or tidal volumes less than 5, or vital capacity being less than 15. Okay, so all these parameters will indicate that this patient needs mechanical ventilation, and also it reduces the work of breathing. All right, and also it improves the gas exchange. If the PaO2 is less than 60 with even 60% of oxygen, so then the patient needs to go on artificial ventilation, because and also if the carbon dioxide is plummeting up like 55 and above, so that is also an indication of type 2 respiratory failure, and they needs to be ventilated. And third indication is a therapeutic indications like head injuries or stabilized chest wall in trauma. So like in head injuries, what we do a thing called neuroprotective ventilation. When the patient is unable to maintain or control his own breathing due to head injury, we have to intubate them and bring them down to neuroprotective ventilation strategies so that their cerebral edema will be less and there's a chance for them to recover. So similarly, to stabilize chest wall, injuries in chest trauma, like if you have a flail segment, to prevent the flail segment coming in and damaging the underlying lung, you'll have to prophylactically intubate them and ventilate until the chest wall is being fixed. Okay, so in invasive ventilation, so so there is a these are the sort of steps that we do. So it is usually attached to an artificial airway, can be the ET tube, and you should ventilate the lungs through the ET tube. Okay, and then can ventilate with advanced ventilatory techniques and modes, and also the dry gases can be humidified by our ventilators, and then it prevents the drying of mucosa. And also it is very easy to suck out airway secretions, as I showed you with the junks that are used during ventilation, like the closed suctioning system. And also it protects the airway from aspiration because of the cuffed endotracheal tubes. Okay, and there are a couple of disadvantages because it requires endotracheal intubation, and for someone to tolerate a tube, they should be sedated. Okay, so that is a disadvantage. And the other issue is, with the endotracheal tubes being in place, there's a high risk for them to have ventilator associated pneumonias. So that's why we try to wean them from ventilators and take the ET tubes out as soon as possible. And also there are complications associated with mechanical ventilation, like pneumothoraces, chest injuries, and they can get barotrauma, volutrauma, atelectotrauma, and lot of other problems. Okay, so those are the disadvantages of invasive ventilation. Okay, so barotrauma means because of the pressure they can go into rupture and pneumothoraces, and volutrauma means because of excessive volume on the lungs. Again, the lungs can get damaged, the alveolar membrane can get damaged, and the diffusing area will be affected. All right, so in mechanical ventilation, so a breath is being delivered by the ventilator. Okay, so it has a start and a stop. So there will be a positive pressure breath that is being delivered from the machine. So if you take this as the pressure line on the y-axis, and if this is the time line, so we will see a pressure rise going up, right up like that, and then that is a active inspiration, or that is a forward flow towards the lungs, and then it stops and equilibrate at some point. And so this is time cycle, so there is a time that is being set on the ventilator for inspiration. So this is the time that we have set on the ventilator for inspiration. So at the end of inspiration, the expiration should happen. So the ventilator stops giving the breath, and automatically the lung starts to recoil. So the same cycle happens again and again. So, so the work of breathing is overcome by the ventilator, and patient don't have to breathe. Okay, so that is what happens. So this cartoon also just shows with the positive pressure how the lungs get expanded, and then when that inspiratory time is over, imagine we have set it for 1 second. So the ventilator will deliver for 1 second and stop, and then it will let the lungs recoil, and again it comes to the next 1 second, goes up and lets the lungs recoil. So that's how it goes on. So this is the sort of simplest way a mechanical ventilator works. So again, this also shows the pressure time graph where you can see the mechanical breath going up and it is plateauing because the inspiratory time is over, and then it lets the breathing to expiration to happen, and the gases will come out. Whereas if you see the spontaneous breathing graph, which we discussed already, you can see the inspiration is a negative pressure creating scenario, and the curve is not that steep. This is very tall, but this is very small, and the expiration also passive, whereas the positive pressure, and it just happens momentarily. So the duration is the same on to the inspiration. Okay, all right. uh, then let's discuss about the ventilatory modes, right? Okay, so there are a couple of ventilatory modes. So this is the most sort of simplest way that I could describe y'all. I'm not going to complicate the picture. So you have a thing called mandatory mode. So in the mandatory mode, the patient is helpless. He will have to take whatever we give from the ventilator. That is the idea of mandatory mode. So it is the type of mandatory mode is controlled mechanical ventilation. So that means the patient does not have a choice. He will have to take whatever we give, and he will not trigger. He will not try to breathe on his own. Triggering means trying to breathe on his own. So that is not there. So we give a breath, he takes the breath. That's it. Okay. So then you have the assisted modes. In assisted modes, you have assist controlled ventilation or synchronized intermittent mandatory ventilation, which is you will have seen very commonly, which is being practiced. Can you all hear me?
Yes,
Any?
madam.
All right. Okay. So assisted modes where there is a assisted pressure, or we will be adding something for the patient, and we allow patient to do something as well. So here it's not like a jail. We allow the patient to do something to the ventilation. All right. So that is assisted mode. We help the patient. If the patient is trying to breathe, we also help from the ventilator. But in mandatory mode, it's like in the jail. We don't allow him to breathe. The machine will look after the patient, and machine will not allow the patient to breathe. But then the next mode is supported mode. In the supported mode, we support the patient more. The ventilator supports the patient more with pressure support ventilation, or with by applying a positive and expiratory pressure. The patient is supported more to get more breaths. Okay. And then we have spontaneous modes where there is the patient is spontaneously breathing, the ventilator is not ventilating at all. It only provides some supportive pressures like a continuous positive airway pressure or a bilevel positive airway pressure, which we have already touched upon, right? Let's briefly discuss. So ventilators are complex machines, of course, to begin with. So it is a machine used to assist or replace the work generated by a ventilatory muscle. So can we ever mimic a ventilatory muscle? It is very difficult, isn't it? Because each and every patient's muscles are so different. So it is very difficult to match to a particular patient. Okay, so what does a ventilator do? It usually facilitates the movement of gases into the lungs, and breath is initiated or triggered by the ventilator or by the patient. Sometimes if the breath is being initiated by the patient, it is called as triggering, or else the ventilator itself can initiate the breath irrespective of what the patient does. Okay, and also there will be oxygen and air mixture that is going into the lungs. So, how does a ventilator decide an endpoint to the delivery of a breath? So, it can be decided either as a volume target or a pressure target. Okay. So, in volume targets, what happens is we set a tidal volume on the um, ventilator, either on the this interface. Okay. So, we set a tidal volume. For example, we set 500. We set 500 for a patient and say, okay, this is the tidal volume. So the ventilator takes that input, and it will deliver only 500 of volume, and that is called as a, so it takes the volume target as 500. So then in that scenario, we call it as a volume controlled ventilation. So that is how we let the ventilator decide the endpoint. Or else we can give him a pressure target. So if we give the ventilator a pressure target, it will reach this preset peak pressure, peak inspiratory pressure, and it will stop there. So when the flow reaches the peak inspiratory pressure, it detects it and stop the flow. So that is called as a pressure control ventilation. So it's very simple. You have two targets, volume target or a pressure target. Okay, is it clear so far?
Yes, madam.
Okay, good. So then I'm just briefly touching upon what is volume control ventilation. So you have set up a volume on your ventilator, and there will be a constant flow of gas until the goal tidal volume is reached, and need to set a respiratory rate and a tidal volume on the ventilator so that patient will get that respiratory rate. And so what happens is when this tidal volume builds up in the lungs, so the airway pressure will pick up, airway pressure will rise. So the only dependent variable is the airway pressure. Based on the tidal volume, the airway pressure will go up. Okay, right. So the other problem is if the lung compliance is low, the airway pressures will be very high. On the other hand, if the lung compliance is very low, the airway pressures is again low because it has more elasticity to expand. Okay, so if the lung compliance is high, the airway pressures are low. All right, and also the flow, because the flow depends on the airway pressure. If the airway pressures are too high, the flow will be less. Okay, right. So those are the sort of variables that we will see on the patient screen. Like I told you, like there are two screens on the interface, two parts, patient's bit and the settings that we enter. All right, and we have the volume pressure control ventilation similarly. So ventilator goes up to a set pressure hold and holds it for a selected inspiratory time, and then the breath is delivered with a decelerating inspiratory flow. So it needs to set a respiratory rate and a driving pressure. So with inspiratory time, which is known as an IE ratio. So inspiratory to expiratory ratio should be there. So based on that, the ventilator will go on delivering the pressure based on the pressure target. So the driving pressure, so the driving pressure is the pressure that changes during a breath. Okay. So during a breath, this driving pressure can change. The tidal volume is the dependent variable, because when we set up a pressure, the dependent variable will be the tidal volume, because based on the driving pressures and the lung compliance, the amount of volume that is delivered will be different. Okay, that's why the tidal volume will be the dependent variable in pressure control ventilation. The simple idea is you can't expect one number in tidal volume when you go on pressure control ventilation. But on the other hand, when you go on volume control ventilation, you will always see one number in volume. In the tidal volume, you will see only one number. Whereas in pressure control, you will not see one number, but instead it will change with each tidal volume. Okay. So the advantage is in volume control, we prefer volume control because the pressure limiting breaths will prevent barotrauma and volutrauma. And the disadvantage is the tidal volume is not guaranteed. Okay, so because as I told you, the tidal volume changes, it keeps on changing. So there's no guarantee that patient gets this amount of tidal volume. So it's just a kind of a graph which compares the volume control with pressure control. You can see in during inspiration, you can see the volume versus time, flow versus time, pressure versus time graphs. So where the volume builds up. Okay, so this is until the second interrupted red line is the inspiration. So you can see the volume builds up according to our target, and because there's more inspiratory time, it plateaus. So it holds on that volume. Understand? And then starts the expiration, and then you can see the the lung recoil, and then the expiration just happens. So it simulates in the flow. You get a forward flow, and then a flow pauses, and then you get a outward flow. Okay, that's why it is positive and negative, right? So when you compare with the pressure control, again you can see the volume picking up, and then it is pressure oriented, so it gets plateaued, the pressure plateaus, and then here also the pressure plateaus, and then during expiration the lung recoils and the pressure goes down. All right. About 20 has already left, isn't it? There's only 51 now. Participants, have they gone home? All right. So mandatory modes. So there are mandatory modes like controlled mandatory ventilation. So as I told you, like patient do not have any sort of option. It only has to take the breath that is being given from the ventilator. So there's no triggering time, and so only time the trigger is to start the breath only. So we have set up a time. So the volume is being delivered in a mandatory way. So there's no place for the patient to breathe. Okay, so we set these targets on the ventilators, and that's how the patient's breath is being delivered. There's no triggering by the patient. Instead, you can see a steady up and down breath that is going on. Okay, and then we have these assisted modes where the commonest mode is the SIMV mode, where you can see the patient triggers, and the patient's breath is being given from the machine, and this red one is patient's own breath, which is being supported by a pressure support, and patients take his own spontaneous breath, very small one, and then again the machine takes up and it gives its own breath that is being preset. Okay, so that is how the patient get a set number of mandatory breaths, and then patient when the patient wants to breathe spontaneously, we support with a pressure support, and then he breathes on his own. So these are the set numbers on the ventilator, where if you want to set up a SIMV mode, these are the parameters that you have to feed in. So I'll discuss about PEEP trigger sensitivity in a little while. So
And there are advantages of this mode of ventilation.
okay, so right, let's see. So then we have this right, so we have these synchronized intermittent mandatory ventilation modes. So there are advantages, the patient comfort, and also it improves ventilatory patient ventilator synchrony, because patient is very comfortable because he is allowed to breathe. Okay, and also you have disadvantages like sometimes patients get so fatigued while being on synchronized intermittent mandatory ventilation. Okay, and there'll be a lot of air trapping as well. All right, and also patients tend to hyperventilate sometimes, so which will again exhaust them. So then we have a thing called the positive end expiratory pressure. We have already discussed actually. So there is a positive alveolar pressure that is being maintained at end expiration, so that it will prevent the collapse of the alveoli. Okay, so it is usually, I mean, very helpful for patients who are in heart failure and who are struggling to breathe, and who needs bit of who has got bit of atelectasis. So all of those patients will be benefited by giving a bit of PEEP into their ventilation. Okay, so then and the expiration is so facilitated by PEEP. So in this graph also you can see number 5, which is colored in red, that is the PEEP. Okay, so in a normal breath you can see this is the peak inspiratory pressure, and this is the P stat, and then this is the PEEP that is being maintained. So it doesn't allow the graph to go down to the baseline, or it doesn't touch the zero. So always there's a airway pressure that is being maintained, so that the small airways are being maintained open, and they are always patent. Okay, so PEEP is beneficial to recruit the collapsed alveoli, and it also increases the FRC. So FRC is the functional residual capacity, and it improves the lung compliance curve and improves the VQ mismatch. So ventilation perfusion mismatches are usually adjusted by this PEEP, and it decreases the intrapulmonary shunting and improves the gas exchange, and also it improves the lung compliance and allows the FiO to be reduced to less toxic level, so that you can spare some oxygen, because giving lot of high fractions of oxygen is not good for the lung. Okay, it can give rise to fibrosis in long run. So aim is to improve oxygen delivery to tissues and optimum increase in PaO2 while maintaining the cardiac output. Okay, so there is a little glitch here. Sometimes when you apply a PEEP, that is a positive intrathoracic pressure, sometimes it can impair the venous return. Okay, so we decide on the PEEP looking at patients' cardiovascular parameters as well. The usual number that we set is 5, but based on patients' oxygen requirement and the worsening of respiratory parameters, we will go up on the PEEP sometimes to 8 or even 10 even. Okay, so then the supported modes the most commonest supported mode that we use is pressure support ventilation. So where patient has a competent drive to breathe. So he's able to breathe on his own, but not ready for unassisted breathing. But he can't do it on his own yet. So the patient will determine the rate, and spontaneous breathing is augmented with a pressure support during inspiration only. So we will give a pressure support for him to augment his inspiration, and patient must trigger the ventilator to obtain the support. So if unless patient tries to breathe, the ventilator will not give this pressure support. So the patient's trigger is being detected by the ventilator. So imagine if the patient is trying to breathe, the ventilator feels a negative pressure. So when the ventilator feels the negative pressure, it will deliver this pressure support that is being set on the ventilator. And volume delivered depends on the compliance of the respiratory system and inspiratory gas flow and the inspiratory efforts, and needs to set a pressure support that allows a delivery of desired tidal volume for the patient. So it depends on the patient's body weight, patient's body habitus. Looking at all that only, we decide on the tidal volume. And you have to sit there and actually see. You can't just set a pressure support and walk out, because you have to see how much tidal volume is being built up by this pressure support. So you have to stay with the ventilator, stay with the patient, and see how they build up the volume. So lastly, the spontaneous modes I have already discussed in my previous slides about continuous positive airway pressures. So in this is one of the spontaneous breathing modes that we commonly use. Okay, and you all can see patients does not need to generate a negative pressure, because it has a continuous positive airway pressure, and is also one of the commonly used non-invasive ventilatory modes. Okay, so triggering. So I was talking about triggering. So triggering means how patient lets the ventilator know that he takes or wants to take a breath. Okay, so pressure, there are two types: pressure triggering and flow triggering. So either the ventilator can trigger the pressure, can sense the pressure, or it can detect the flow. So a patient drops the end expiratory pressure by a preset amount of 1 to 4 centimeters of water. When it drops the pressure, like um, when somebody is trying to take a deep breath, that is like he's trying to suck out air from the ventilator, isn't it? So ventilator triggers it as a pressure drop. And similarly, it can detect as a flow trigger, like the ventilator can feel it as a flow being produced towards the patient. So you can adjust the trigger. If you want your patient to breathe even smaller tidal volumes, or even smaller respiratory breaths, if you respiratory attempts, if you want to support onto your patient, you have to reduce the trigger. So if you want your patient to breathe hard, or if you want your patient to breathe bigger breaths, you have to increase the trigger. Okay, so that is the idea of trigger, right? Which is a number that we need to set on the ventilator. Okay, so in this graph, you can see on this Christmas tree looking graphs, the first ones are the assisted ventilatory numbers, ventilatory graphs. You can see a inhalational upstroke. This is like a continuous mandatory ventilation. Okay, and then that is the exhalation. But when the patient starts to trigger, when he attempts to breathe, there is a little negativity that is created, and the ventilator will sense this, and then it will initiate another breath. So it will help the patient to breathe. So it goes up and comes again, and again the ventilator feels that patient is trying to breathe, and the ventilator supports. So it goes up and comes down. So that is the same thing that is being shown here as well as a pressure drop. Can you see here the patient is here and now he's on a PEEP, and all of a sudden patient tries to breathe. So there's a negativity created. Negative pressure is created, and this is the trigger threshold that we have set on the ventilator as 4. So when it reaches 4, the ventilator will allow, and ventilator will provide some pressure support. Now this is the pressure support it is providing, so it will allow the patient to breathe. So that is patient's breath. Okay, right. So that's all I wanted to tell you all. Have you all got any questions to ask? Did you all understood? So M15031, can you tell me what is the trigger? What is ventilator triggering? M15031.
The patient
the patient tries to breathe by himself.
Yes, very good. And then the ventilator senses it, isn't it? And then Gayatri, can you tell me what is PEEP? Gayatri M15093. What is PEEP? I think everybody is quickly leaving so that, yeah, what is PEEP? So what is PEEP? Gayatri, are you there?
Hello. Yes, madam. Can you hear?
Yes, I can hear you.
Is positive in expiratory pressure.
Okay.
Hello.
What does it do?
It is the pressure in the lungs.
Is there a lecture at 3:30? I saw it just now. Is there a lecture at 3:30? I was not aware about it. Did Dr. Vasila was planning a lecture at 3:30?
Madam, the lecture's cancelled, ma'am.
Oh, really? Okay.
Yes.
Okay, I didn't know it was not scheduled on my this thing. Okay then. All right. Have you all got any doubts to ask? Any clarifications? Any doubts, clarifications? You all want to do? Anything to be asked? No? So then I'll wind up, okay? Somebody would have
Okay.
interrupted me and told so that I would have stopped at 3:30. At that time, just interrupt me and like I will not see the chat box sometimes, okay? So just stop me and ask, right? Okay. All right then. Let's wind up.
Thank you, madam.
All right. Thanks for listening. Okay.
Recording stopped.